All right, Benita, I have 11:02. Let's say we go ahead and get started, if that's okay with you.
Sounds great.
Excellent. Welcome, everyone, to April's edition of the Task Talks hosted by the KHDSP Task Force. As a friendly reminder, please mute your microphones when you're not speaking today. I will be moderating the chat, so if you have any questions, feel free to enter them into the chat. And I will make sure that our speaker gets to them before the end of the presentation. We are going to try to keep this webinar to just 1 hour. So now I would like to introduce the Kentucky Heart Disease and Stroke Prevention Program Manager. She's also a Task Force Steering Committee member, Benita Bobo.
Good morning, everyone. Thank you all for joining us. I'm so thrilled to have Dr. Kanotra with us today so we can learn more about the Kentucky Behavioral Risk Factor Survey. She is the project director. She is a PhD, MPH, and CHES as well. Her responsibilities include coordination of the Kentucky Behavioral Risk Factor Survey, BRFS is what we call it, at the Kentucky Department for Public Health. She's supervising not only the primary contract for this, but she also has the completion of the annual cooperative agreement, monitoring funds appropriate through the agreement, and ensuring that approved upon provisions are maintained throughout the year. She makes sure that the data is available to all divisions in DPH for risk factor reports and responding to data requests from other governmental agencies and the public. That's the official, but I can tell you they do whatever we ask them to do. No matter what I ask, her and Jeeves always come to our rescue. So can't thank them enough for always being there for us, and I'll turn it over to Dr. Kanotra.
Thank you so much. I really appreciate the opportunity to talk about BRFS. And we all know that it's not a very sexy topic. Let me share the screen before I mess it up. Okay. Sorry, I'm like being clumsy. David, what happened? Can you all see my screen?
You got it. Yep.
I got it. Thank you.
We're good.
So it's a mouthful. So this is we are talking about the Kentucky Behavioral Risk Factor Surveillance, and as Dr. White nicely calls it, BRFS as the a country in Europe. And my dear friend Shelley thought it was like barfing, and I'm like, no, it's not barfing, it's BRFS. So here we go. So as I say, my program collects the Kentucky uglies. So anytime you see the America's Health rankings come up, we always see, and it's sad, but it's ranked as one of the nation's least healthy states. So anything you call about the risk behaviors, chronic diseases, preventive practices, that is part of what we collect in the Kentucky Behavioral Risk Factor Surveillance. So what exactly is, let's just start with BRFS, So this is a state-based survey system that is conducted by all health departments in the 50 states in the nation, as well as the territories. And this is done with assistance from the CDC. So as CDC always wants us to say, it's the longest running telephone survey system in the world. So as I said, that this is the mode of data collection is through phone, and not just like the phones means it needs both. It uses landline and cell phone. And the primary focus is mainly behaviors that are linked to leading causes of death, like smoking and obesity. As I just said, that these are what type of data is collected, all the health risk behaviors, the clinical preventive practices like, have you done your colonoscopy? Have you done your mammogram? Have you got your pap smear done? So all of this information at a population level, and as I say, at a population level is obtained through this survey. So what do we call it in Kentucky, y'all? As I said, I've learned how to say y'all. So we had to make it like us. It has to be Kentucky, you know. So in Kentucky, we call it KyBRFS. So nobody barfs in Kentucky. This is what we are. Kentucky Behavioral Risk Factor Survey. So if you see the sign, and anytime someone calls you on your cell phone and it says we are calling as part of Department for Public Health and CDC, please do respond to that call because it really makes a difference. So I would like to thank Jude, who is part of this little team that we have, as Bonita keeps saying. So without him, I would not be able to complete most of the data requests that we get. And funding, as I said, it is co-sponsored project from CDC as well as the Department for Public Health. So what type of data is collected by us? Okay, so I'll talk to you a little bit about the questionnaire because it's a science. And I enjoy explaining it to my students actually. So this is a very long questionnaire, but what I say, it's a complex questionnaire. So it has approximately 150 questions. But if I tell you that, you know, you have to answer 150 questions, especially a male and a young male, do you think they will, like, you know, complete the survey? So I thank all of my interviewers who, you know, get this information for us. So we have but when I say a complex survey, you are not supposed to answer all of those questions. Why? Because this is a complex survey with skip patterns. So if you're a healthy person and you say you do not have diabetes, you do not have heart disease, and you do not have, so those questions are not asked to you. So as I said, it has a core question. And I also said that this is part of the survey which is throughout the nation. So core is asked by all 50 states in the nation. So that is how we can compare apples to apple. And even in the core, we have three portions. We have a fixed core, we have a rotating core, and an emerging core. And when you say emerging core, you're like, what do you mean by emerging core? So see, questions like COVID-19 are immediately put into this. So if we want to know what is the status of vaccination by geographic regions, we can give it to CDC on a weekly basis. So these are some of the demographics that we ask in the survey, and it helps us give a picture of who has the problem. You know, and I keep saying BRFS is a pointer. It gives you the snapshot. It does not give you the entire picture, but it starts to give you the importance of the problem, that this is the problem and which needs to be solved. So as I also said, that it talks about 13 chronic conditions, starting from arthritis, COPD, asthma, heart attack, coronary heart disease, stroke, skin cancer, impaired vision, kidney disease, depressive disorder, and diabetes. So we come to know about 13 chronic conditions through this survey. And as I also said, that it has a rotating core. That means in odd years, we ask a particular set of questions, and in even years, we ask another set of questions. So in odd years, I get a lot of breakups because we are asking a lot of questions about fruits and vegetables. You will not believe. People will answer you questions about ACEs, which are very, very sensitive. But if I'm asking you, how many fruits do you eat? They break up. I've heard, like I monitor this survey, so it's surprising. So hypertension awareness, cholesterol awareness is all in the odd years. Even years, we are asking more about the cancer screening. And these are, so not only the core, the fixed core and the rotating core, the states have the ability to add some questions. It's not a big portion, but we do have some ability. That's the flexibility of this survey. We can add certain questions as state added. And you've seen, like, Kentucky being Kentucky, we add a lot of tobacco use questions. And we have also added COVID-19 questions last year. We've added questions about opioid use, drug recovery. So you can see, like, we have a varied, questions that have been asked. And these questions are what comes from you as data users. This is not what I add. And so if you are part of my data users group, you have the ability to add these questions in KyBRFS. And not too much, but a little bit, I'll tell you, the science of data collection. So we do not randomly call people and say, oh, by the way, can you complete the survey? No, we have a computer-assisted telephone interviewing system where the survey comes on the screen. It has a software. The survey questions come on the screen, and the interviewer is asking those questions. So we have, CDC provides us with numbers, and it's not us. So please don't, think that we get your private numbers. We get it from CDC. So we have numbers that are they are part eligible numbers of home people who are living in residences or on cell phones. So we dial the number, and if it's a non-residence, we stop calling it. If it's residents and we can determine the eligibility, we will call it like 10 times to see if that person can answer. But if you are like really rude or you really do not want to answer, we will stop calling it and call it like, it'll be stored in a database where nobody will call that number. So anything that we are calling it's a randomly generated phone numbers. And even when we are selecting, even if you answer my call, I will ask you how many people are living in your residence. And then I will select who that person would be who would respond to my call. And if you are on a cell phone, we make sure that you're not driving. If you're driving, we will stop calling and ask you what is a better time to call. So the main timeline, if you see mostly, the timeline is annual. So we start for a new survey. We will start asking questions from January 1st to December 31st of the current year. Like 2021, I started in January 1st, and I will cut it down on December 31st. So on a monthly basis, we submit our data to CDC, and they weigh the data. And why I say weighing the data means that I collect data. I collect approximately 7,500 completed interviews, but the population of Kentucky is 4.1 million. So if I want to generalize my data for the entire Kentucky population, I need to weigh that data based on the demographics of the population and that weighting is done by, it's a very sophisticated way of weighting. That methodology was started in 2011 when we introduced cell phones in the survey. So that is done by CDC, and CDC releases that data by the fall of the coming year. So for example, if you're looking for 2021 data, that will be made available to you in September of 2022. So as I said, Jules and me, we create certain reports, and these are the kind of, so all the core questions, immediate tables, tabular format, we make available in this format. So alcohol consumption, arthritis, cardiovascular disease, we will provide that data immediately by nationwide and what Kentucky is, and also by the 14 stratum that we have of area development districts. So we make it available in our ADD profiles. This is how we provide it. And then this is a snapshot of what the 2018. So we also create annual reports that takes longer. And this is how we will present our data. This is one of the way in the annual report you will see what is the, say, percentage of Kentucky adults who have coronary heart disease by age, education and income. So you can see, you can all see like by age, it's older age, but look at what makes me sad is every time when I see this heart disease or any kind of disease by education and income, you can see a kind of a slope. So as your income is increasing, the prevalence of the disease is decreasing. But as your education is decreasing, the prevalence of that particular chronic disease or risk behavior is increasing. And so in the annual report, we also, this is, as I said, we have 14 strata, the area development districts, and we present the data by area development district. This is something you will not find on the CDC website. And this is something like most of you might be interested about. You have several initiatives that are being done by Kentucky that are, that Bonita is, has been doing these initiatives. And how, like, what kind of people, like when you are asking the questions, who responds to, has a doctor or nurse recommended you to check your blood pressure outside of the office or at home? So this is the kind of tables that we create for self-reported blood pressure measurement. So this is one of the answers to one of the questions. So these are some of the reports that are generated using data. And the reports are not created just by us. The reports are created by our partners, by our collaborators, by our data users. So for example, I have Dr. Terry Wood, who will always let me know, Sarojini, I have a legislative report to complete. And a lot of data is used by that report from KyBRFS. Then I have a very good partner in the Foundation for a Healthy Kentucky, and they have created several reports using BRFS data or KyBRFS data. And then we have fact sheets that have been created by diabetes, by heart disease, by asthma program. And one of this is by the maternal and child health division. They have created, and all of you must have heard, data about ACEs, adverse childhood experiences. That data also comes from KyBRFS. So that data, if you're looking for that data, you can go to our website and look for the fact sheets that are available. We asked these questions in 2015 and then again in 2018. So you would ask me, so how do I access this data? And I will go like interactive to show you how we can access Kentucky data. How am I doing time-wise? Okay, I'm good.
You are doing good. We have 20 after 11, so you're still doing okay. But I do have a question as long as you paused.
Oh, no
someone in the crowd, Lynn Hundley, has asked, do you have current fact sheets on stroke at the moment?
Current fact sheets, see, if she needs it, yes, I have it. Because we create kind of, our annual report has like one-pagers that can be used as fact sheets.
And you have one current for stroke?
Yes, 2019.
Excellent. We will make sure we get that after this presentation.
Yeah, 2019.
Thank you.
You are very, very welcome.
I'm here, I'm at the beach.
Thank you. No, this is what our job is. And the more you use our data, the better we look. Trust me.
Well, I'm excited to get to the data access piece. So if I need to go hunting around.
And any questions you can ask me, right? Stop me and just ask me, because I'll show you how to use the data. Okay. So I think now I might have to go to the other, okay. So I'll start with the CDC's website, okay? Can you see the screen? Okay.
Yes, you are doing good.
This is the CDC. If you type in CDC, all of the links are in the PowerPoint. But just if you even put CDC and BRFS, you will get this. So if you look at this, there's a lot of information available here. But what we do, if you are wanting information, immediate information about, say, Lynn, you're looking for stroke, okay? So we go into, so you will get information by state level. You will not get information by ADD, that you get from us. But information about state level, you hit this prevalence data and analysis tool, okay? And again, it takes you to another page. And again, if you see here, there's a lot of information that is available to you. You have smart data, you have prevalence data, you have chronic disease indicator, and WEAT, web analysis tools. So this, when you have the time, you can always, browse. But I would suggest first you get used to, if you want to, get information immediate, quick and dirty. So this is what we are. We are Kentucky. I selected that. And you want information about stroke. Okay. So I go into the chronic health indicators. And you want, and I'm like, where is the stroke? Okay, cardiovascular disease. And see, look at the ear, Lynn. So I hit this. Okay, so here you go. Ever told you had angina or coronary heart disease? Ever told you of heart attack? Ever told you? So I like to get this, see, you're seeing this, you see these two? I like to look at it as a table. Okay, so this is like me as a person, and it's easier for me to, so if you look at this, you know that 4.9% Kentuckians said that they had stroke. Again, in this, if you see here, you can also look at trend data, all available years. It'll give you trend data, and you can also look at it by gender. Look at it by gender. So if you want to see how is it by gender, by race and ethnicity. By race and ethnicities becomes a little harder, because although we oversample minorities, sometimes it's not enough. See, if you will see here, you will see asterisk marks. If the respondents are not enough, it will not give you that information. And you can also look at by education attained. Okay, easy. So you can see, look at that. It's like less than high school is 10.4. Just look at that figure. And also the good part is you can also look at all available years. So anytime we are looking at trend data, we always suggest that you do not compare anything before 2011 with the data, because there was a lot major changes that occurred in the BRFS data. So look at this, all of the years. And in this, you can also, I can change it to this web format, and there you go. And you need to see this. See, you want this save as a PDF or an CSV file that you can convert it into Excel. Okay, so let's go to another one. I'm going into another. Do you have any questions, anyone?
No, thank you. I see the error of my ways. It was my searching. I wasn't doing it right. So that's wonderful. You just showed me exactly what I was doing wrong. Thank you.
That's good to know. Sometimes that's the best. Okay. And I'm sorry, I need to go back to my share screen. And so now I will be talking about the cabinet's website. There's the cabinet websites, not the best, but you can get all the reports that we publish here. So if you go, this is our website, not the most beautiful, but you see here, we have the KyBRFS data reports. They don't even put it properly, KyBRFS, but I'll make the changes. But you look at the area development profiles, and you will see the annual reports and special fact sheets.
Sarojini?
Yes?
We're still looking at your PowerPoint. Did
I'm sorry.
New share button come up?
Oh yeah, I did. I thought I did select it, but thank you, no problem.
There we go. Now we got the cabinet webpage. Thanks.
Just didn't want to. So this is our cabinet webpage. Beautiful cabinet webpage. So we have you can click on the KyBRFS data reports, and it'll take us to the area development, profiles and our annual reports, special fact sheets. So, and like ACEs fact sheets. So I'm going back to another, Oh, and this will be your really, this website, and I thank the Environmental Tracking Network for this. This is the best that could have happened to us. Okay. So there you go. So this is the Kentucky Environmental Public Health Tracking website. And here you can get data at county level. I will not suggest that. We hesitate to provide data at county level, mainly because of 120 counties. We have like 120 counties. And in 120 counties, if I'm collecting 7,500, completes, there is a possibility that I miss even in an area development, and I'm collecting it by the strata, like area development districts. Like Bluegrass has like 15 counties. So when I'm picking up randomly respondents, I may not pick up from particular county. So if the participants are less than 50, we do not give out that data. So if I give out that data, it's statistically unstable, and people may get false or they get wrong results, and that can be interpreted in a very different manner. So this is why I'm always hesitant. We are always hesitant to provide data at county level. But here, what is good is that you can collapse years and get, sometimes if the population of a county is higher, if your denominator, like simple, if your denominator is higher, you can get good results. So let's go to the data portal here. And when you go to data portal, so this will be your friend if you're looking for data. This place not only KyBRFS, but other, definitely, even mortality data, population estimates, and even like social vulnerability index, because we know all of us know that sometimes we have to give data quick and dirty. Grant applications, they'll ask you like weird type of data, but this is one of the place that has all data, all Kentucky data, let's just say. So look at this. It has hospital admissions also, emergency department visits. So you, as working with heart disease, may need some of this data, but I will focus on mine. So I'm prejudiced to mine. So we have the Kentucky data of BRFSS. So you can see here, we have data about the healthcare coverage and the access to healthcare. Then the good part is they have, divided it as we have it in BRFS. So let's talk about like chronic conditions. So let's go to doctor diagnosed coronary heart disease. Okay. So if you see here, you will see years 2011 and later. So it could be crude rate or age adjusted rate. Age adjusted rate is your friend, but BRFSS being a population level, we don't necessarily suggest you need to have age adjusted rate, because we already have done the weighting. So if you will see here, you will see that we started it, I think, in 2016 onwards for age-adjusted rate. So I normally go to the crude rate. That's the habit. So let's go to 2011 and later. It'll ask you to hit here. And then it's asking me, I'm looking for doctor diagnosed, okay? Then it's asking me what year. I said 2018. And it's asking me, okay, what geographic area? I don't want to select county level. I will select area development district. It will give me for county level too. And I'll show you, let me show you first county. I say, oh, okay, all counties. Let's do that. And I'm saying, okay, let's submit it. It's asking me several questions. And so look at this. So the counties that are showing white does not mean they did not have the data. It just means that the data has been suppressed, if that makes any sense. Because there was not enough data there for it to be represented here. Make sense? So let's go back and and select area development districts, okay? Because that is what I'm comfortable. I'm collecting at least 500 completes by area development districts. So look at it here. You see a nice map, and you can tell, okay, the darker the color means the higher. So if you look at this, this is what Reed River, and if you look at up, there's a index there. So it has the 11.3 is the value. So 11.3 is the prevalence of coronary heart disease in the residents living in Green River. And then you're looking at here, Kentucky River, Big Sandy. So you know what are the culprits here. So you can see, it'll give you all the information. So if you're looking at bluegrass, the prevalence is 5.4. Okay? And we see it's also giving you data here, right here. It has the tables too. So all of it, if you are doing a grant, writing a grant, and you want information about your like area development district, the problem comes when it's a county that has lower population. And the good part here is you can also look at it by local health departments. So if you see there was something like local health departments, I'm hoping they have enough data here. But see, again, even by local health departments, you will see areas where, you know, these are this, like Mercer County, you see no data available. So that is why I always prefer to, you know, provide data by area development districts. There is another source, and I will go, this is my last, okay. Okay, so you can also look at county health rankings. Let me do the new share. Can you see my screen?
Yes, you're good.
Okay, perfect.
Thanks.
Okay, thank you. And so let's go. Is there any county anyone wants to look at specifically? Or let's do something. We can do a smaller county and we can do a bigger county. So let's do, say, Franklin. Oh, I did not spell it right. So when I'm saying Franklin, if you see how many Franklins come up. So this is County Health Rankings is a project done by Robert Wood Johnson Foundation, as well as University of in Wisconsin. So this is a very good source of data if you want something by county level. So if you look at this, so for Franklin County, it's telling you that it's higher middle range of counties in Kentucky with like by health. So it's giving you by health factors, by health outcomes. And so this is giving you so many information about what's the length of life in people living in Franklin and what is their quality of
Sarojini,
life.
your volume is down.
Oh, 1 minute. How is it now? Can you hear me?
Yes, it's good.
Loud and clear.
Okay, thank you. So here, so if you see, this is a tabular format of telling you all the indicators of Franklin County. So it's giving you what's the premature death rate in Franklin, well, how good the people are living there, and what is their quality of life, what is it's poor or fair health, and then it compares you to top US counties as well as Kentucky. That's the good part about it. So you can see here poor physical health days, poor mental health days, what's even the low birth rates, and then it'll also tell you about the adult behaviors, adult smoking, adult obesity. It does not take care of everything, but it takes care of several behaviors. So clinical care, so you can also look at the level of uninsured, how many primary care physicians are there, how many did, so all of these. It will also give you high school completion, then unemployment, how many children are in poverty, and income inequality. So it gives you more than, like, if basically this is also one of the good sources that you can use to know data about at county level. A lot of what BRFSS, BRFSS provides this data from CDC to county health rankings. And this data, why I say it's a good data is because it's like, even for smaller counties, they have actually used small area analysis. This is a specific way of analyzing data to give you data at county level. Because when I am giving you data at county level, I can only give you for counties that have a higher population, not for all counties, or I'll have to collapse years. Okay. And another thing about this website is it'll also give you initiatives that other counties similar to you are taking for addressing an issue. So it's not, it'll give you like several other, so how to take action and what works for health and who you can work with. So you can find partners in other counties which are similar to yours demographically and other factors similar. And it'll give you that, what are the counties that are similar to yours? And you can look it up and actually contact those people and, work with them on certain initiatives. And they also give actual small grants and prizes if working with the University of Wisconsin and Robert Wood Johnson. And my last county, but not the last website that I would, and that is a work in progress. As I said, we have partners with the foundation. So they have another place. Do you see my screen? So we have, again, foundation has a Kentucky Health Fax, and they use a lot of our data. And if you go into the resources, you can get several places like links to good data sources, and you can look at data by location. So you can actually, again, look at certain things by county level. But again, their way of giving you data can be a little different. Again, they may be collapsing the data. by years or collapsing some contiguous counties. So I always suggest that, be careful whenever you are using the data. And if it's not making any sense, we are always there to answer questions that, you may have about the particular data. You may say, oh, cabinet is depicting this data for this particular county, but in Kentucky Health Fax, we are seeing the data in a different level, or in CDC, it's giving you a different way of data. So it's always good to maybe reach out to us and, ask us for data, like if we can, provide the answers. And so coming back to our slide. So pretty much we have taken care of all the, okay. Okay, so this is what I have already, this was just so that, if interactive data things doesn't work. I'm almost done. And if you see, this is how, as I said, you can see, look at the, just looking at the counties by data. If you look at the counties, you can say that this is your Appalachia region, the most healthiest county. And I've joined I'm the state team lead for data for county health rankings. And I think I joined this county health rankings project in 2011. And since then, I've been seeing, like, if you look at this, Oldham County is the most healthiest county. And we all know that Oldham County has the highest per capita income too. So this gives you a good, visual, which are, because it's like dividing the counties by quartiles. You see that? So this outcomes means their quality of life and length of life. So length and quality is really bad in this area. That is 91 to 120. So ranking is done just to see how the citizens are in that particular county. So someone or the other, it shifts, it keeps shifting. Someone will be in the last and someone has to be in the first. So they do the ranking on an annual basis. So this is 2021 results. And they also do it by factors. So they say that not everything that happens in the doctor's office. This is what their rationale is for depicting data. So this is the length of life and the quality of life. And this gives you, so some counties that may be really bad in the health outcomes may be really good in health factors. That means the way they live. So mostly I'm seeing in the Appalachia, see if you look at these counties here, it may be bad in outcomes, but health factors, it's better. That means the environment of living in that area is better. Some other factors may be good. So how do we use KyBRFS data, and so definitely we use in the cabinet, we use this data mainly. It starts with writing grants and getting funding. Because as I said, this is like a CDC grant. So we add questions into this survey in the state portion of the survey. And as I have not explained earlier, whatever goes into the state portion of the survey is what is decided by my data users and my steering committee. And the chairperson of my steering committee is the commissioner of Department for Public Health. So Dr. Stack today will decide what goes into the 2022 KyBRFS survey. So we start looking for proposals or questions that need to be added in fall of this year. And that is how we, people like universities, the foundation, and programs like Bonita is a very good partner, because they normally add questions almost annually every year about, say, anything about self-measured high blood pressure or even salt-related behavior. So they will add questions, and tobacco users add questions about the smoking cessation. And as I said, this project, the KyBRFS, depends on data users. It depends on data users. So when the data users are adding questions, we are also generating revenue for completing this data collection. And I don't think any one of you have asked me, because it is public use data file, so we cannot ask public to give us money for using this survey. But we do spend, at least on an annual basis, I'm spending $500,000 to collect this data. So I keep asking my partners, data users, to help me generate revenue to complete. So on, as I said, we are doing currently 80% is cell phone and 20% is landline. So now the landline data collection is very expensive. So one completed landline cost me approximately $100 per completion. So when you kind of add it up, that comes to be almost more than $500,000. So when we generate, say, CDC gives us part of the grant, but it does not give us the complete grant. So KyBRFS depends on, our sponsors, like the health department programs, the universities, the foundation. The foundation I would really need to mention is Foundation for a Healthy Kentucky has been very generous to us and helps us in oversampling African-American population. So as I said, the population in Kentucky for African-Americans is, say, 8%. But so in my 7,500 completes, I need to make sure that at least 8% of my population is African-American. So for me to do that, I need to oversample the African-American population. That adds to additional funding, needs for additional funding. And the foundation has been supporting us for doing that oversampling since 2011, and actually 2009. So using this data has been definitely used to analyze health trends. And it has definitely helped us in developing policies and legislation. And when I say development of policies and legislation, I do not mean that Kentucky BRFSS was the only data that was used to develop the policies. It feeds into, so it's a snapshot, as I said. So if you all have heard about the SB 89 bill for tobacco use, so they have used a lot of this data to start their infrastructure, to talk to the legislative people, to start like talking about them, that how much tobacco use was a problem in Kentuckians. So they also use Quitline. And then I can give you another example of, I have Kentucky Cancer Consortium as very good partners. And they have added questions on barriers to colon cancer screening. So initially, Kentucky was very, very low in colonoscopy, prevalence of colonoscopy, residents who had done colonoscopy. But through the years, they saw that the prevalence rate had become kind of static. So they said, why is it that people are not going to get their colonoscopy done? So they added questions about the barriers that could be faced by these residents. And those questions, lo and behold, they did tell us, like, there was options like, I don't need colonoscopy. And I was one of them, in fact. So, and I was like, another was like, my doctor did not, tell me to have a colonoscopy done. I am scared of colonoscopy. And again, I was one of those, till my good friends who are all nurses and I really love them. She literally pushed me every day. Sarojini, have you got your colonoscopy done? So I'm just saying that they added these barriers, and we came to know that the top barrier was that I don't need it and my doctor did not tell me. And once we made KCC Kentucky Cancer Consortium shared this with physicians, they were not very happy about it. And so in 2008, we got this result. In 2012, when we added this question again, the prevalence of physicians telling that barrier was lower. The prevalence of that barrier was lower. So this is how we use, these are some of the ways that we use KyBRFS data. Definitely, we use it to plan and measure the progress of prevention initiatives, and that is something that Bonita's team does on a very regular basis for evaluation purposes. And we monitor health goals, such as those now that we have in Healthy People 2030. And definitely it helps in educating the public about risk behaviors and preventive health practices. And definitely it's very, very crucial for the contracts and grants. I think I am on time, thank God. Okay, and this is our team. And this is just this is just me and Jude, but that being said, I have the entire chronic disease branch as part of my team. Sue Thomas Scott, who's the branch manager, she's a firm supportive of KyBRFS. And then we have each program manager who's part of the support team for us. And then we have Dr. White, who is a very firm proponent of KyBRFS. If you hear her talk about ACEs, I can guarantee you will be crying. I have never cried, but the way she presents that data, is excellent. So we are part of a team, and I appreciate and acknowledge everyone that has helped KyBRFS grow. And now we are for questions. How am I on?
I'd like to start and say thank you, Sarojini. That was excellent. I learned, I've been working with her for quite a few years, and I learned a lot today. And I do have a question really quickly.
Okay.
Lynn asked about the stroke fact sheet. Is that something that is on where we can access those, or is that something that you all develop and then we just get from you?
We will develop, and I'll make sure all the information is there. Because the thing is, as I said, we specifically do not create that fact sheet unless it's requested. But in our annual reports, each page is can be taken as a fact sheet. So we will share with you what we have, and you can let us know what you want to add, and then we can share it with the data users and all of your team.
Perfect. Thank you so much.
You're very welcome. So no questions. I did so well.
Sarojini, if you would like to give me the screen back, that would be great.
Yes, definitely,
and
definitely.
Does anyone else have any questions? You can unmute yourself and ask them. You can put them into chat. Getting some thank yous. Carrie Moore is definitely interested in the stroke fact sheet. Cindy Sullivan says, thank you so much. It's been helpful.
And we can always, if you let us know what exactly you're looking even for the stroke fact sheet, because we will analyze it by race. We will analyze it. We will compare it to the country. We will give you by area development profiles, and we will analyze it by education, income, and age. But if you need any other information, don't give it. Don't ask by county, okay? That's the only thing I cannot do, because that's not possible. But you look at the smaller, see the number of people who are responding becomes smaller and smaller by each condition. So, and then the denominator of it becomes smaller. I will not give you statistically stable data if I give you, by county. So, but if you have something that we can provide it to you, definitely we will try our best. But these are the things that will be there. Yes, Lynn.
This was great. I love the whole presentation. For the fact sheet, I heard you say you compare the Kentucky to the U.S. Those of us that go out and do stroke education always like to see that. How does Kentucky compare to the United States? Because
Okay.
unfortunately, every risk factor for stroke is higher in Kentucky, percentage-wise, than the rest of the United States. And it's always, it'd be nice to be able to see, has that gotten any better or not? The last few times it still looked pretty bad. So I was interested to see if any more current information is out there and if it looks any better.
And we can give you the trend data, Lynn. You saw that, you know, compare it. Like I can give you the trend data, how it looks through the years in Kentucky as well as in the United States. So that'll show you the curve. Where is it going?
Yeah, that's kind of what I was trying to get out of it. Yeah, absolutely.
No, I understand. You know, data presentation. So getting data is important, but also presentation of the data.
Absolutely.
Is very, very critical.
People have to understand what they're looking at. So absolutely.
Yeah, yeah. I agree with you totally. So any other questions?
All righty. Well, if nobody else has any questions, I'm going to share something. Sarojini, thank you so much for joining us today. It was great, as everybody said. Let me put this up. A couple of notes. I will be sending out an attendee survey next week. Please fill it out. Let us know what you thought. Good, the bad, the ugly. Let us know if you have any ideas or suggestions for future task talks. We'd love to hear about it. I will get a meeting recording up sometime in early May with any resources, Sarojini's PowerPoint, links to all of the websites that she references. It sounds like it may take us a little bit on the stroke fact sheet, but when she gets that, I will post that as well. Also, our next task talks is not going to be until June. That's on the bottom of the screen, June 24th. We're not going to do one next month because next month we will have a task talks or a task force meeting. The first one since 2019, Benita, I believe. That's going to be Wednesday, May 26th. It's going to be from 10 till 3, and registration should be coming out very soon. It will be 100% virtual. We'll do it through Zoom, and more details to come. Benita, do you have anything else to add?
No, again, just want to thank Sarojini for an excellent presentation and for everyone for joining us. Again, I learned, and I've been working with her for quite a few years, so it's always nice to have such an informative presentation so that it can help and enhance our work. Looking forward to that stroke fact sheet, like I know Carrie and Lynn both are as well. So we'll be working with her on that. And just know that the registration for the task force meeting will be going out, so you can have that link and it will go into your calendar so that we can make sure that everybody gets it on their calendars and we can have a wonderful get together, even though we have to do it virtually.
Excellent. Well, thank you, everyone. Enjoy the rest of your afternoon, and we will hopefully see you all at the task force meeting on May 26th.
Thank you.